Hello readers of KJR. It's a pleasure to have a chance to introduce our article with this video clip. The title of the article is Effects of Implementing Artificial Intelligence-Based Computer-Aided Detection for Chest Radiographs in Daily Practice on the Rate of Referral to Chest CT in Pulmonology Outpatient Clinic. I am Wonju, the first author of the article. Artificial intelligence-based computer-aided detection for chest radiographs has shown excellent performance in many previous studies, and now it is widely used in clinical practice. The ultimate goal of using AI CAD is to improve the quality of patient management and outcomes, but the clinical impact of CR interpretation using AI CAD beyond the interpretation accuracy has rarely been investigated. Chest radiograph is used as the initial screening exam for the presence of various respiratory diseases, so the initial clinical decision influenced by the CR interpretation would be the need for a referral to chest CT to confirm the CR findings. Therefore, the purpose of our study was to investigate the influence of the clinical implementation of AI CAD for CR interpretation in daily practice on the frequency of referral to chest CT in patients visiting pulmonology outpatient clinics. This is a single-center retrospective study performed at a tertiary referral hospital. We included patients who were referred for CRs from outpatient pulmonology clinics between January 2019 and December 2020. A commercialized AI CAD system was used in clinical practice since January 2020. It was designed to detect pulmonary nodules, consolidation, and pneumothorax, and displayed the location with a heat map when the probability of abnormality was equal to or more than 15%. Pulmonologists were informed that they could request CRs including AI CAD analysis, and the referring pulmonologist decided whether to request CR with or without AI CAD analysis. All CRs were interpreted and the formal reports were provided. Pulmonologists could also evaluate the CRs and AI CAD analysis results immediately after CR acquisition, regardless of formal reports. The primary outcome of our study was the CT referral rate, defined as a chest CT request by the pulmonology department after CR acquisition, followed by CT within 30 days of CR acquisition. CT requests from other departments, those before CR acquisition, and CT scans obtained 30 days after CR acquisition were excluded. The secondary outcomes were frequency of positive and negative CT results followed by CT referrals. CT reports indicating findings that require further evaluation or treatment were considered as positive. We also investigated the referral frequency to CT before documentation of the formal report by radiologists. This is a case with positive CT finding. AI CAD identified abnormality in the right upper lung field on CR, and CT obtained 8 days after CR acquisition showed a nodule, which was eventually diagnosed as lung cancer. This is a case with negative CT finding. CR showed nodular opacities in left middle and right lower lung field. Chest CT obtained 19 days later showed a calcified granuloma and bone island, which did not require further evaluation or treatment. Multivariable logistic regression analyses were conducted to evaluate the effect of AI CAD implementation on study outcomes. The following independent variables were included. This is a flow chart of the study design with numbers of the included CRs and patients. The crude study outcomes were compared, multivariable logistic regression analyses were conducted, and generalized estimation equations were adopted for multiple CRs from a single patient. Among 54,434 CRs, 25,888 CRs were obtained after AI-CAD implementation. 13.2% were requested for AI-CAD analysis. This table shows the demographics and characteristics of the study cohort. Baseline CRs and positive CR reports were less frequent after AI-CAD implementation. Overall CT referral rate was 3.8%. 37.5% and 62.5% CT exhibited positive and negative findings respectively. CT referral rate, positive and negative CT referral rates, and the frequency of referral to CT without CR report were higher in CRs obtained after AI-CAD implementation. In multivariable logistic regression analysis, use of AI-CAD was independently associated with increased CT referral and increased negative CT referral, but not with positive CT referral nor with the referral to CT without CR report. The most strength of our study is that we investigated the impact of AI-CAD implementation on clinical decision-making. As using AI-CAD could be a double-edged sword leading to unnecessary additional exams, the increased identification of false positive findings may be the leading cause of increased CT referrals. Our study demonstrated that using AI-CAD was not associated with a referral for positive CT. It could be that CT referral could be influenced by various factors in patients with significant respiratory diseases visiting pulmonology department, regardless of CR finding. Also, in clinical practice, timely interpretation of CR by a radiologist may not always be possible. Therefore, appropriate education and guidance from clinicians for use of AI-CAD are necessary. There are our conclusions. CT referral rate increased after clinical implementation of AI-CAD. Using AI-CAD was an independent factor for CT referral. Referral to negative chest CT also increased after AI-CAD implementation and was independently associated with using AI-CAD. We hope that readers could understand and have concerns on the impact of using AI tools in daily practice and finding a great way to use them more effectively. Thank you for listening.